Thank you, Professor Hesham. I think we'll go to questions after each talk, not to the end. Any question for Professor Hesham before leaving the stage? Can I start by myself, Hesham, please? رغم إنك قايل لي لا. Anyway, coming back to the clinical practice on your daily practice, if you have a patient, EGFR mutant patient, failing on the first and second line oral TKIs, could this patient, EGFR mutant patient I mean, could be a candidate for immunotherapy or chemotherapy?
In the second line or first line?
Maybe third line.
Yes, I think there is, in some clinical trials, we can try immunotherapy in some patient with mutant EGFR after failure of all lines. Maybe the ATEEZ or the Valo, we can try this treatment on this trial and these settings. I think also it is very important area to go for more intense clinical research, like the triple negative or considered triple negative and the combination area.
To my own opinion, if you allow me, please, I think this category or subset of patients, I have to do PD-L1 testing for EGFR mutant patient before going to immunotherapy, because we have data, positive data on immunotherapy in EGFR mutant patient, in second line I mean, or third line, and you have negative data. So I think this category of patient is mandatory or is mandatory to do PD-L1 testing for them before starting immunotherapy, yes. I think.
Dr. Hesham, please, I'm asking about the treatment with immunotherapy beyond the progression of the disease versus giving chemotherapy after failure of immunotherapy.
As in the recommendation of the panelists last year, that it is area of needing more research. As we revise the summary of trials, that we have some trials showing some benefit with more than 30% improvement with treatment beyond progression, and the other, like the renal study with Professor Escudier, that there is no improvement in this setting.
Can I have a small comment, please, if you allow me? I think the continuation of treatment or treatment beyond progression, I have to define what is meant by beyond progression. I have to select the proper candidate to continue beyond progression. We have strong data from the OAK study, tumor continuation beyond progression, so long as your patient did not show any worsening of his performance, worsening of his symptoms. You have to categorize, and you categorize your patient to continue. And definitely continuation in this category of selected patient beyond progression is definitely superior than chemotherapy.
It's very difficult to go for selected patients. Selected patient is a very political word. So it is, we cannot select who will benefit from treatment beyond progression. So it is, and I think it is very important to define and to go for more research to as you said, to try to select more these patients who will benefit beyond the progression.
I said, Dr. Hesham, the data from the,
from the
OAK trial, only the OAK trial. Okay, thank you, Professor. I'm sorry. Last question.
Microphone, please.
Somebody here from the IT, we need a microphone for the doctor here to ask, please.
Just 1 minute, she's coming. Yeah. This gentleman on the right.
The microphone is coming.
Hello. What a great presentation, Dr. Hesham. My question is actually a practical question. You said that it's for the PDL testing as a first line, it's a mandatory. You know, in some of the cancer centers, they don't have the PDL testing and they send it maybe abroad and sometimes will take time. this is just a practical question. Should this justify using it without doing the PDL in the first line?
No, I don't recommend, and I think all the panelists not recommending to go for the first line, without testing of BD. Yes, even if you cannot go for this, so it is. Yeah, I think all the panelists are agreeing for this. If you don't have the BDL1 testing, it is not recommended, in my opinion, to go for immunotherapy in the first line, because till now we have some failure in the first line with other drugs. So it is most important to treat. Not all the agents or checkpoint inhibitors are like others. So it is very, very important to stick to the clinical trials.
I think
you are going to comment? Okay.
one second, sure. I think for the first line, we have the data to do the PD-L1 testing. It is mandatory in the first line setting, except if you look at the Empower 150 of the combo as first line, irrespective of the PD-L1 status. But we have to wait. Up to this moment, PD-L1 testing or biomarker assessment is important in the first line.
Okay, Dr. Hesham, please, I have a comment because you have mentioned the combo, and I think there are ongoing trials addressing this point. Which type of patients would be suitable for this more or less intensified therapy?
It's a very important question. We have a positive results in progression-free survival. The overall survival data is still immature in both trials, the Keynote 21 and the Empower study. And I think we will listen from Professor Niredi a lot of things today about this. And in my opinion, I don't recommend now the combination, except after going for a very, very good selection. The cost of the treatment is very high. We must go for more this intensified treatment with a lot of cost and high cost. It's very important to select patients who will go for this treatment.
Okay, I'll have a comment on Professor Hesham. I think in the second line setting or more, the combo, whatever the combo is, I think the subset of patients with PD-L1 negative tumor will benefit from the combo if we compare it to the PD-L1 positive patient. So I think the combo, forget or put aside the cost and the toxicity, the most ideal benefit or efficacy will be for PD-L1 negative patients and not PD-L1 positive.
Any other question? If not, thank you very much, Professor Hesham. Now, our second speaker.